Hello, everyone. Today, we will study the knee joint, a connection of the lower limb bones. The knee joint is formed by the distal end of the femur, the proximal end of the tibia, and the patella. It is the largest and most complex joint in the human body. The patella articulates with the patellar surface of the femur. The medial and lateral condyles of the femur oppose the medial and lateral condyles of the tibia, respectively. The joint capsule of the knee is thin and loose. It attaches to the margins of the articular surfaces. It is reinforced by ligaments around it to increase joint stability. The main ligaments are 1. The patellar ligament, which is the central fibrous band of the quadriceps tendon. It extends downward from the patella to attach to the tibial tuberosity. The patellar ligament is flat and strong. Its superficial fibers pass slightly over the patella to connect to the quadriceps tendon. 2. The fibular collateral ligament is a cord-like, tough fibrous band. It arises from the lateral epicondyle of the femur and extends downward to the head of the fibula. Most of its surface is covered by the tendon of the biceps femoris muscle. It is not directly connected to the lateral meniscus. 3. The tibial collateral ligament is broad, flat, and band-like. It is located on the posteromedial aspect of the knee joint. It arises from the medial epicondyle of the femur and attaches inferiorly to the medial condyle of the tibia and the adjacent bone shaft. It is tightly integrated with the joint capsule and the medial meniscus. The tibial and fibular collateral ligaments are taut during knee extension and relaxed during knee flexion. They are most relaxed when the knee is semiflexed. Therefore, in the semiflexed position, the knee joint allows slight medial and lateral rotation. 4. The oblique popliteal ligament is an extension of the semimembranosus tendon. It arises from the medial condyle of the tibia, runs obliquely upward and laterally, and attaches to the lateral epicondyle of the femur. Some of its fibers blend with the joint capsule. It prevents hyperextension of the knee joint. 5. The cruciate ligaments are located slightly posterior to the center of the knee joint. They are very strong and lined by synovium. They can be divided into anterior and posterior cruciate ligaments. The anterior cruciate ligament arises from the anterior part of the intercondylar eminence of the tibia. It is fused with the anterior horn of the medial meniscus and the anterior horn of the lateral meniscus. It runs obliquely upward and posteriorly. Its lateral fibers are fan-shaped. It attaches to the medial side of the lateral condyle of the femur. The posterior cruciate ligament is shorter and stronger than the anterior cruciate ligament. It arises almost vertically from the posterior part of the intercondylar eminence of the tibia. It runs obliquely upward and anteriorly, attaching medially to the lateral aspect of the medial condyle of the femur. The cruciate ligaments firmly connect the femur and the tibia. They restrict anterior and posterior displacement of the tibia relative to the femur. The anterior cruciate ligament is tautest during knee extension and limits anterior displacement of the tibia. The posterior cruciate ligament is tautest during knee flexion and limits posterior displacement of the tibia. The synovial membrane of the knee joint is the most extensive and complex in the body. It attaches to the margins of the articular surfaces of the bones forming the joint. It covers all structures within the joint except the articular cartilage and the menisci. The synovium protrudes upward above the patella, forming the suprapatellar bursa, which is about 5 centimeters long. It lies between the quadriceps tendon and the lower part of the femoral shaft. On either side of the midline below the patella, the synovial membrane protrudes into the joint cavity, forming a pair of alar folds. The folds contain adipose tissue, filling the spaces within the joint cavity. There are also bursae that do not communicate with the joint cavity, such as the deep infrapatellar bursa located between the patellar ligament and the proximal end of the tibia. The menisci are 2 crescent-shaped fibrocartilaginous plates located between the femoral condyles and the articular surfaces of the tibial condyles. They are called the medial meniscus and the lateral meniscus, respectively. The medial meniscus is larger, C-shaped, with a narrow anterior end and a wider posterior end. Its outer margin is tightly connected to the joint capsule and the tibial collateral ligament. The lateral meniscus is smaller and approximately O-shaped. Its outer margin is readily connected to the joint capsule. The menisci have a concave upper surface, a flat lower surface, a thick outer margin, and a thin inner margin. Their ends are attached by ligaments to the intercondylar eminence of the tibia. The peripheral zone has capillary loops from the joint capsule, while the inner region is relatively avascular. The menisci make the articular surfaces more congruent, also alleviating pressure, absorbing shock, and acting as elastic cushions. The menisci also deepen the articular socket and, together with the femoral condyles, allow rotational movements of the tibia. The position of the menisci changes with knee joint movement. During knee flexion, the menisci slide posteriorly. During knee extension, they slide anteriorly. When the leg is rotated with the knee semi-flexed, one meniscus slides forward while the other slides backward. For example, during knee extension, the tibial condyles along with the menisci slide forward along the articular surfaces of the femoral condyles from posterior to anterior. Because the curvature of the posterior part of the femoral condyl's articular surfaces is greater than that of the anterior part. During extension, the contact area between the femoral condyles and the tibial condyles gradually increases. Correspondingly, the two menisci also gradually slide forward. Because the menisci move with knee joint motion, sudden and forceful movements of the knee often cause meniscal injury. For example, when suddenly extending the lower leg with forceful rotation, such as when kicking a soccer ball, if the menisci do not have time to slide forward, they can be crushed between the articular surfaces above and below. This can result in crushing or rupture of the menisci. Because the medial meniscus is tightly connected to the joint capsule and the tibial collateral ligament, the medial meniscus has a higher chance of injury. Injuries or disorders of structures within the joint are often diagnosed and treated using arthroscopy. The knee joint, being a large, superficial joint prone to injury, and having no major neurovascular structures on its anterior, medial, and lateral aspects, is most suitable for the application of arthroscopy. Well, in this class, we have studied the knee joint. In the next class, we will begin studying the ankle joint. Thank you.